Good afternoon, everyone. It's 3 p.m. local time here in Ghana, and we are all welcome to this week's presentation. This webinar is courtesy Ghana Medical Help and the Department of Medicine, Upper West Regional Hospital. This week, we would be looking at peripartum cardiomyopathy. You realize that it cuts across a diverse group of people like you would be seeing in the presentation as well. Would also require some multidisciplinary team approach. So just like I see on the platform, we have the pediatricians, we have the obstetrics and gynecology department people joining us as well, and then the gynecologists. A few housekeeping rules. You'll notice that when you join in, your microphone is automatically muted. You would be unable to unmute yourself so that inadvertently you wouldn't have to do this. Kindly make use of the chat box to put in your comments, your questions throughout the presentation, so that at the end of the presentation, we would be able to discuss these questions, these comments, and of course, when and if we do have time, then we would allow some verbal questions and comments so that then we could make this presentation very rich. Like we started doing at the beginning of this year, at the end of this presentation, we would put in an evaluation form, which takes just less than a minute to fill in, so that you'll be able to evaluate the presenter and the entire presentation. And then we'll take notes for improvement. So kindly, it's an important part of our presentation. So kindly do make use of this so that we can get the presentations improved to meet what you would want us to do, and as well be a learning point for us. This afternoon, Dr. Richard Vire, sorry if I got the name wrong, would be taking us through the presentation. Is on peripartum cardiomyopathy. Kindly join me to welcome Dr. Richard. Dr. Richard, please go ahead. Thank you.
Good afternoon. I'm Dr. Richard Vire, as you rightly said. Today, I'll be presenting on the topic peripartum cardiomyopathy and supervised by Dr. Dominic Akatiba. So the outline for this presentation will be the definition, epidemiology, etiology, pathophysiology, signs and symptoms, management, complication, differential of peripartum cardiomyopathy.
Dr. Richard, sorry to interrupt. Like I indicated, you need to speak loud because I see comments already coming up that your voice is extremely low. Thank you.
Okay, thank you. So peripartum cardiomyopathy is an idiopathic cardiomyopathy with the following characteristics: the development of heart failure towards the end of pregnancy or the last month of pregnancy, or within the first 5 months of after delivery, or the absence of another identifiable cause of heart failure. Left ventricular systolic dysfunction with an ejection fraction less than 45%. However, peripartum cardiomyopathy can be diagnosed even in left ventricular ejection fraction between 45 and 50 if the patient has typical clinical features of the peripartum cardiomyopathy without any identifiable cause of heart failure. The epidemiology: there is insufficient data on the incidence on peripartum cardiomyopathy in Ghana. However, peripartum cardiomyopathy occurs globally and affects all women of ethnicity in all continents. The incidence rate varies widely depending on the geographical locations. There are some few published incidents of peripartum cardiomyopathy. In Sweden, there was a published data on peripartum cardiomyopathy, which is 1:5,171 in Sweden. In US, it was between 968 to 1:4,000. That of in Canada, it was 2,400, and that in South Africa 1:1,000. That in Haiti 1:300. That in Nigeria 1:100, which makes Nigeria the most common cause of this particular condition. However, the cause of this part, the epidemiology actually depends on how it was being conducted. In Upper West region, there were no clear data on the peripartum cardiomyopathy, but there were few cardiomyopathy and cardiomyopathy related diseases. So in the first quarter of 2020 and 2021, we had no condition of cardiomyopathy, but we had related conditions, which were 37 and then 46. The second quarter was 4 for cardiomyopathy, 55 for related disease. That was for 2020, and 2021 was 13 for cardiomyopathy, 67 for related heart diseases. The third quarter was 17 and 21 for cardiomyopathy for 2020 and 2021 respectively. The last quarter was 22 and then 18 for cardiomyopathy. Now, the exact cause of this particular condition is unknown, but it may be multifactorial. There are many potential mechanisms which exist and may result in a single pathway called the vasculohormonal hypothesis, which is also called the 2H. In this particular pathway, there is an it is mostly enhanced with oxidative stress, the cleavage of prolactin fragment, and impaired vascular and endothelial growth factors signaling because of the upgraded soluble FMS-like tyrosine kinase. There's also an idiopathic imbalances. These idiopathic imbalances as a result of the SFLT1, which actually neutralizes the VEGF secreted by the placenta in the late gestation of a pregnant woman. So when this particular SFTL1 is increased, it actually neutralizes or reduces the effect of the VEGF. This particular hormone is mostly found in preeclampsia and then multi-gestational pregnancies, which is actually one of the risk factors for this condition. So the etiopathophysio, there are, as rightly said, there are no clear cause for this particular condition. However, there are other theories that suggest the possible mechanism for this condition. So one of them is the prolactin, and then the prolactin. When the prolactin is increased, there is an increased reactive oxygen species, which cleaves the the prolactin into a 16 kilodalton protein, which is associated with the endothelial and myocyte apoptosis. Now, there are other pathophysiology mechanisms which are the genetic predisposition, inflammatory inflammatory causes, viral, which can be the viral myocarditis. There's also another theory that relates to the mechanism being nutritional factors. That is when there is a low selenium in the patient. And then there's also another pathophysiology which is related to the autoimmune factors. Now, the risk factors mostly are based on advanced age. However, there are other researches that have shown that women with even younger ages have presented with this particular condition. Multiple gestation, as rightly said in the prolactin theory, it's also one of the risk factors. And then multiple parity. It is also stipulated that multiple parity is a risk factor. However, it is noted in patients who have delivered one or twice and had presented with this particular condition. Black race is one of the risk factors because even from the epidemiology, Nigeria and South Africa was leading in terms of the epidemiology. Long use of tocolytics has also been associated with this particular condition. Preeclampsia or eclampsia, as stated in one of the mechanisms, is also a risk factor of this particular condition. So a patient may present with symptoms, but these symptoms is mostly, the severity is mostly based on the New York Heart Association to classify the extent or the severity of the symptoms of the patient. So the class 1, the class 2, class 3, and class 4 symptoms of the New York Heart Association is mostly used to know the severity of the patient's symptoms. So the clinical manifestations or the symptoms that the patient may present could be cough, pedal edema, orthopnea, right hypochondrial pain, dyspnea on exertion, epigastric pain, PND, and then distended abdomen. On a clinical examination, the pulse may be normal. The pulse may be normal, may be increased, or may vary. The blood pressure may be normal, increase or decrease in patients who present with peripartum cardiomyopathy. The JVP may be increased above 8 centimeters. But bipedal edema, pitting edema may be present in patients who present with this condition. The apex beat of such patient when palpated may be diffused, displaced either laterally or laterally and inferiorly. S3 gap, which mostly in pregnant women may be normal, or it's found in normal pregnant women, but can also be a sign picked up in peripartum cardiomyopathy. In a decompensated form, the patient may also present with pulmonary edema, so crackles may be picked up on examination. Ascites and hepatomegaly may be picked up on abdominal examination of patients who present with peripartum cardiomyopathy. So the management, actually the management entails a very good history, a thorough physical examination and investigation investigation and treatment. So a patient who presents with peripartum cardiomyopathy, the age of the woman is ideal because one of the risk factors is advanced age. The parity, which is also a risk factor, the drug history, whether the patient has been on any tocolytics, to help us know how to make a differential or to separate it from other differentials. Then the past medical history, whether the patient has had previous history of pregnancy-related condition of such, or whether the patient has any hypertensive heart disease. A thorough examination will also help us to elicit signs which may differentiate or may help to differentiate peripartum cardiomyopathy from other causes of heart failure. So the investigation is actually to help rule in or rule out other causes of heart failure, since peripartum cardiomyopathy is a diagnosis of exclusion. So investigations are carried out to rule in or rule out other causes of heart failure when presented, or when patient come, pregnant women or postpartum women come in heart failure. Now, the treatment is mostly, the treatment of the patient will also depend on the type of the heart failure, if it is peripartum cardiomyopathy. So the investigation can be grouped into imaging and then laboratory investigations. So with the imaging, echo is actually a key imaging to use in diagnosing this particular cause of this particular heart failure, because we need the ejection fractions need to be measured, whether it is less than the 45%, is between 45, 50, or it is more. Now, which will also help us to know what could be the cause of this particular heart failure. Now, it also helps us to know if there are any valvular pathologies, the size of the chamber, and then the motion of the heart walls. Chest X-rays can also be, when done, can help to know whether there are cardiomegaly, there's pulmonary congestion, or pleural effusion. ECG may show sinus tachycardia, non-specific ST elevations, and T wave changes. P wave and QRS intervals may be prolonged in patients with peripartum cardiomyopathy. Actually, ECG helps to make other differentials of heart failure, such as myocardial infarction, which the ECG can help us to differentiate it from peripartum cardiomyopathy. Cardiac MRI is one of the developing imaging tool being used. But this one is used mostly when there is other detailed information have to be picked from the investigation. When the echo is not able to pick that, the cardiac MRI is used. However, it is not suitable in pregnant women or patients who have this particular condition but have not yet delivered. Endomyocardial biopsy is one of an invasive procedure, but it is really not a recommended investigation used because of its invasive procedures and its invasive nature of it. So the laboratory investigation of this part of peripartum cardiomyopathy There is actually no specific biomarker for peripartum cardiomyopathy. However, some laboratory findings may help us to exclude or include other differential diagnoses. Brain natriuretic peptides is a screening biomarker in heart failure, but it is not specific for peripartum cardiomyopathy or pregnancy-associated disease. So this particular hormone, when elevated or seen, is not actually specific for the peripartum cardiomyopathy or heart pregnancy-related disease, because it's a marker for heart failure. So it could be any cause of heart or any form of heart failure, even if it is elevated in a patient. Normal range values can also help to rule out heart failure, so the patient presenting with signs of or symptoms of heart failure, this particular hormone will help us or will help to rule out heart failure. So cardiac enzymes may also be investigated or may be used in this particular condition. But it, as rightly said, it is not, there is no specific biomarker, but it's just to help to rule out or rule in other differentials. It may be increased in normal pregnancy or cesarean section. If normal deliveries, creatinine phosphokinase may be increased in normal deliveries or cesarean section, because this particular enzyme is not only found in the heart, it is found in the other muscles. So muscles and then bones. So this part, when elevated, does not necessarily mean it is a pathology of the heart. It could be any form of pathology related to the muscles or related to the bones. It may be increased in viral myocarditis, which could point or help to know that this particular, as one of the mechanisms of peripartum cardiomyopathy. So it will help us to tilt our investigation or our focus towards making a diagnosis of exclusion, of which will help in knowing which particular cause, what is the cause of the viral, what is the cause of the heart failure. Troponin I and T may be used. It may be elevated, and which may indicate, its elevation actually indicates the myocardial disease or infective myocardial infarction. So its elevation will help to also make a differential diagnosis of heart failure, which will help to rule out peripartum cardiomyopathy. So other laboratory studies are the full blood counts, which are supportive, but may also help to make other inputs in a diagnosis, because anemia may complicate heart failure. Infections may also complicate heart failure. The LFT, the liver function test may also may be seen elevated if there's a right heart failure. So it's the LFT may help to know the extent of the heart failure or the symptoms and signs that the patient is presenting. Urinalysis actually in pregnant women is necessary because one of the risk factors in peripartum cardiomyopathy is preeclampsia or eclampsia, and then proteinuria is one of the criteria used in preeclampsia or eclampsia. So an elevated protein in a pregnant woman will give a clue what could be the possible cause of the heart failure that the patient is presenting. Serology tests like viral, HIV, syphilis, Chagas disease may also be tested because they are all possible risk factors of the peripartum cardiomyopathy. So there's no specific treatment for peripartum cardiomyopathy, but the treatment is actually a collaborative recommendation from other forms of heart failure with reduced ejection fraction. So the treatment is extrapolated from heart failure with reduced ejection fractions. In peripartum cardiomyopathy, if the patient has not delivered, mostly it is a multidisciplinary approach. That is, the obstetrician is needed or is part of this approach. The anesthesiologist is part of this approach. The cardiologist and then perinatologist is also part of this particular approach. However, if the patient delivers and the condition of the patient is still not improving, it is still a multidisciplinary approach. So it is not the treatment of this particular condition is basically a multidisciplinary approach as needed to take care of this patient and then the unborn or the born baby. So women who are actually stable on medical therapy can continue with pregnancy with close monitoring. Stable women can go through vaginal delivery if there's no contraindication to vaginal delivery. So the treatment actually can be grouped into non-pharmacological and pharmacological. The non-pharmacological, one of the key things is to educate patients to reduce salt intake, bed rest. There's a need for bed rest in severe cases of peripartum cardiomyopathy. However, strict bed rest is also a risk factor for venous thromboembolism. So if the condition of patient is not all that severe, there is no much need for strict bed rest. If the patient can ambulate, it's better for the patient to ambulate to prevent this thromboembolism, because pregnancy is even a risk factor of thromboembolism. So ambulation will also help to prevent this particular thromboembolism from occurring. So pharmacologically, the state of the patient is to be taken into consideration. So whether the patient is still pregnant or the patient has delivered. If the patient is pregnant, the medical therapy is actually taken into consideration concerning and then putting the fetus or the unborn baby, putting the unborn baby also into a factor. You have to factor the unborn baby in the treatment of this particular or the patient. If the patient has delivered, that is after delivery, then the lactation or the baby is also taken into consideration with the reason of lactation and then the medication. So when the woman is still pregnant or during pregnancy, one of the first medications or first line of medication to use in the heart failure or in heart failure in patients like this is the diuretics. Mostly the furosemide is used. Beta blockers may be used. However, if the patient comes with wet chest, it's advisable that the chest is dry before beta blockers are initiated. Hydralazine may be used in patients who are still pregnant and are presenting with heart failure. Sodium glucose transporter 2 inhibitor, such as the dapagliflozin, the DAPA and then the MPAC may be used because it is proven that it helps to reduce the cause of mortality in patients with heart failure. Digoxin may be used with care because of the risks of the embolism, thromboembolism. Low molecular weight heparin may be used. Warfarin is contraindicated in pregnancy, so low molecular weight may be used with care. ACE inhibitors or ARBs or MAR are contraindicated in pregnancy. So after delivery, if patient present with or diagnoses are made after delivery, there are some medications that can be used, even though they are contraindicated in pregnancy, but after delivery, they may be used with care or with caution. Diuretics may be used, or is one of the first line to be used even after delivery. It is safe to use in women after delivery who are presenting with peripartum cardiomyopathy. Beta blockers are also may be used or are one of the medications to be used in conditions like in this condition. But as I rightly said, the chest needs to be dried before the initiation of beta blockers. AC inhibitors, especially enalapril and captopril, may be used with care, with caution, because the other AC inhibitors still has the potential of the potency of crossing through the lactation into the baby, and may have some effect on the baby. But enalapril and captopril has been proven to be a little bit safer in lactation or breastfeeding. Spironolactone may also be used in breastfeeding. Anticoagulant is actually indicated in this condition because lactation, or in lactation, there's also still possibility of thrombosis. So anticoagulant is actually indicated. Patient with left ventricular ejection fraction less than 35 or 30, with a 30 from the American College of Cardiology, we will say 30, but the European Society of Cardiology will say 35. Patient with such or with this particular left ventricular ejection fraction, that there's a need for the patient to be put on anticoagulants to prevent thromboembolism. So the treatment, there are other experimental treatments which are being used, but they are used as its use is considered as experimental. It may be used after discussion between the physician and patient has taken place. Because one of the mechanism of peripartum cardiomyopathy is related to prolactin. Bromocriptine is indicated in some of the studies as one of the treatment for peripartum cardiomyopathy. So patients who are being put on this particular medication should be treated or should be put on therapeutic anticoagulant because bromocriptine increases thrombolytic complication in patients. Therefore, they should be treated or put on therapeutic anticoagulant therapy. There's another experimental treatment with the use of antiplatelet agent. This particular antiplatelet agent also is from the experimental point of view. Therefore, if a physician or the physician and the patient needs to come to an agreement before using based on the evidence from trial, so that the patient and the physician will all be at the same level before use. So in peripartum cardiomyopathy, patient who has not yet delivered and present with this particular condition, as I rightly said, it is a multidisciplinary approach with the cardiology, the obstetrician, and anesthesiologists and then neonatologists are actually needed in the management of this patient. There's a little data on the timing and the mode of delivery. So it is actually the mode of delivery is based on the stability of the patient. The timing of delivery is actually based on the stability of the patient. So patients who are actually hemodynamically stable can be allowed to go to vaginal delivery with close monitoring. However, patients who are not hemodynamically stable, despite medical treatment, the disciplinary approach is needed to come to a conclusion on the mode of delivery, which is mostly, the mode of delivery is mostly by the obstetrician or the gynecologist, the obstetrician, the cardiologist, and anesthesiologist, and then the neonatologist. Now, cesarean section is actually indicated in patients with advanced heart failure, peripartum cardiomyopathy. So with the issue of breastfeeding, there are other school of thoughts. One school of thought, which includes the European Society of Cardiology, had the school of thought that lactation may worsen the condition of the patient. Therefore, advocate that lactation should be prevented in patients with peripartum cardiomyopathy. So this comes to the or boils down to the point of the effect of the prolactin, which is one of the assumed mechanism of peripartum cardiomyopathy. However, the American College of Cardiologists have also had a different view about breastfeeding. They recommend that patient who is clinically stable should not be discouraged from breastfeeding as long as the breastfeeding is compatible with medication patient is on. So as long as patient is stable, with the American College of Cardiologists, they go with the view that patients should not be stopped from breastfeeding. because they view the benefits of breastfeeding to the baby and then to the mother. So because research that were done with patients who had peripartum cardiomyopathy with, and then had the research showed that there was no adverse effect on the patient's health whilst breastfeeding. So they advocated that patients should not be prevented from breastfeeding as long as patient is stable, and then medication which patient is on is not contraindicated in breastfeeding. So there are complications of peripartum cardiomyopathy because it's a heart failure. So there are complications, and this complication can be from the point of, or can be grouped as maternal and then fetal. With the maternal, thromboembolism is one of the main complications of peripartum with patients with peripartum cardiomyopathy. The patient may progress. Patient condition may be progressive. There may be arrhythmias in patients with peripartum cardiomyopathy. Hypoxia is also a complication of patients with peripartum cardiomyopathy. The fetal complication, fetal distress due to maternal hypoxia is one of the complications of peripartum cardiomyopathy in the fetus or the unborn baby, on the unborn baby. So this distress may also be as a result of placenta hypoperfusion. So subsequent pregnancies and then contraception. When patient is diagnosed and then being managed as a case of peripartum cardiomyopathy with heart failure, after delivery, patient should be counseled on the need to be stable before the next pregnancy if she wants to conceive again. So spacing of pregnancies is a key, one of the major ways of preventing reoccurrence or reducing the incidence of reoccurrence or the worsening case of the heart failure in peripartum cardiomyopathy. So patients should be counseled on contraceptive options. The type of contraceptive to be used in this particular condition is also important. Patients with such conditions should not be, it's not ideal to be put on estrogen contraceptives because estrogen increases the risk of thromboembolism. Progesterone, although it's a second line contraceptive in patients with heart failure, it also has a risk factor. It also has a risk of increasing fluid retention in the patient, thereby worsening the condition of the patient. So it's more appropriate to put patient on non-estrogen containing contraceptives like the copper IUD, the levonorgestrone releasing IUD. So patients who are on a particular medication which are teratogenic in pregnancy should be stopped or should be reviewed before conception to prevent any adverse effect on the fetus. So there are other differentials of peripartum cardiomyopathy. So the patient may be dilated cardiomyopathy, hypertrophic cardiomyopathy, preeclampsia or eclampsia, hypertensive heart disease, valvular heart disease may all be differential diagnosis of peripartum cardiomyopathy. So for peripartum cardiomyopathy to be diagnosed, all these differential diagnosis should be excluded before a diagnosis of peripartum cardiomyopathy is made. Thank you.
Thank you very much, Dr. Richard, for the presentation. Quite a couple of people did complain about your low tone voice, but I'm sure we got a lot out of it. It was quite comprehensive and cuts across right from pregnancy till delivery, and of course calls for the multidisciplinary team approach, which you kept highlighting on. So great job done. I'm sure it will stimulate a lot of interesting discussions. And since we would zoom in straight to that and have those discussions done. Just to acknowledge that we've been joined by Dr. Odalis. Dr. Odalis is my boss and the head of Department of Medicine at the Tamale Teaching Hospital and a senior lecturer with the University of Development Studies School of Medical Sciences. She's the head of department as well. Thank you very much, boss, for joining us. Also, Dr. Kelly Hartfield, who is the CEO and founder of Ghana Medical Health, did join. And then I have a couple of colleagues as well, right from Dr. Matilda, the pediatrician, and Dr. Gildas as well, the obstetrician gynecologist. So obviously, it still hammers on the multidisciplinary team approach to the management of such cases. So we have a rich panel. And so if you have any thing that you've been stimulated with through this discussion that Dr. Richard led us in, kindly let us know in the chat box, and then we can address those as well. Once we are done with that, we would have opened the platform so that then you can electronically raise up your hand and you make your most valuable contribution. Just again to highlight the fact that we usually would want to evaluate what we have done. So I'm just going to put up a survey in the chat box so that within a minute, it's just a yes or no answer. And then down there, you suggest other topics and what you think could have been done better with this presentation. It's quite helpful when we do this because it helps us to get a feedback of what we have done. The presenter gets to know where he should have improved on. And more importantly, we get to know what better we can do with subsequent presentations. So as you would find in the chat box now, I've put up that link there. Kindly click on it, and within a minute, you would be done. It's quite important to us that you do this. Now to the questions that have been put up in the chat box. The first one comes from Infinix Hot 10T. Unfortunately, we don't have the person's name. So it's a question which states that why are selective beta blockers used during pregnancy in peripartum cardiomyopathy? Dr. Richard, do you have an answer to that?
It's in the treatment of heart failure. Actually, selective beta blockers is one of the, or is the best to go. So, and peripartum cardiomyopathy is a heart failure. So in treating such a patient, we need to use the selective beta blocker instead of the non-selective beta blocker, which may affect other organs and causing more, which has a lot of effect on the body than the selective beta blocker.
Okay, great. So like he rightly said, obviously heart failure will look at going in for the selective beta blockers, not non-selective generally. But more importantly, I think the question did want to highlight the fact that in peripartum cardiomyopathy, rather than just the selective beta blockers, we actually want beta-1 selective. Example is the metoprolol. And these are usually preferred to ones that have both blockade of beta-1 and beta-2. And the reason is that the beta-1 selective blockers would less likely interfere with the uterine relaxation and peripheral vasodilation. You realize that anytime the uterine relaxation and peripheral vasodilation, like in basic sciences, they will usually teach us, is mediated by beta-2. And so if you go ahead to block both beta-1 and beta-2, then obviously the beta-2 mediated uterine relaxation and peripheral vasodilation would be off. And this is not something that you want to interfere with, is that also? A caveat or something that we should, however, take note of is atenolol, which is a beta-1 selective, should not be used during pregnancy. The reason is because of its effect on the fetal growth. It causes fetal growth restriction. And actually, I remember a cardiologist that joined us during ground rounds in Kolebu, cardiology ground rounds, and we mentioned a patient that was on atenolol, and I think he laughed his head over and wanted to actually see the atenolol because he thought this was a drug for the museum in where he was practicing for over 5-10 years. He hadn't seen atenolol in clinical practice. So it's something that we should be careful about, especially in this special and selective group of people, those who are pregnant. And so I think it's good that that question did highlight that and brings that out clearly. Thank you. Then I think same person, hot T10, says, is peripartum cardiomyopathy reversible with treatment? Do you have an answer to that, Dr. Richard?
It may resolve or progress into the worst form of it, depending on other risk factors of the patient. So after delivery, the patient symptoms may resolve, and then the condition may become better off. But if there are other risk factors related to the condition, which will actually precipitate the worsening of the condition, then it will move into the worst part of it, especially even the next pregnancy of the patient.
Great. Yeah, so of course, this again highlights the need for the multidisciplinary team approach, is that not it? Even following delivery, usually we don't leave the woman alone. And you realize that in his presentation, he kept highlighting on the fact for the need for follow-up, because a couple of people would have persistent LV dysfunction. You realize the definition did take a key component at looking at the left ventricular ejection fraction, which is clearly outlined in the ESC, that's the European Society of Cardiology guidelines for diagnosis of peripartum cardiomyopathy. And like we usually say, essentially it's a diagnosis of exclusion. And so usually following the delivery and all of that, you would ideally want to follow up these patients primarily to ensure that they recover their left ventricular function. And even those who have normal LV function, the risk of LV dysfunction during subsequent pregnancies, although as compared to those who have persistent LV dysfunction, it will be lower. But if you compare it to the general population, it's still way higher. So obviously, it will mean that you need to follow them up. Direct answer to your question is that this LV dysfunction can become normal, and that's actually what we want to. But the risk is still real, even if the ejection fraction goes above 50 following the first episode and following delivery. So it doesn't mean that, one, you can have a normal function following it, but your risk of getting a subsequent peripartum cardiomyopathy, or even what they call pregnancy-associated cardiomyopathy, is higher than the general population. So true, you can have normal LV function, like normal recovery following it, but we do not leave you alone. We still need to follow you up, because even with that, the risk will still be there. And so it's something that we would want to follow you up, because you could develop heart failure symptoms following that as well. And then, like he rightly did indicate, with regards to subsequent pregnancies and all of that, usually, essentially, it's a multidisciplinary team approach, and we need to sit down with the patients and then do what we call the MDT management. And of course, involve the person in whatever that is going on so that they get to understand, likely also the husband and all of that. I think recently we've had 2 cases of such. One of them, we had a discussion with the family regards that. I remember during residency training in Kolebu, there was a patient that we had such a meeting with. The next time we saw her at the clinic, she was 4 months pregnant. What can you do? You just have to do what is essential. But of course, if you highlight the need and you keep doing it at each clinic visit, I'm sure even if it's hard to drum home a point, it would raise some concerns with the family. So thank you for your question. The next one from Dr. Odalis, say thank you so much for inviting me. Thank you, boss. And it was a good presentation. So thank you very much, Dr. Richard, for leading us in such. Fatah wants to know whether furosemide is safe in pregnancy. Dr. Richard, do you have an answer to that?
So furosemide is safe in pregnancy, and it's one of the medications to use in acute settings of heart failure. But because of the fetus, when using furosemide, care should be taken so that the patient will not cause hypoperfusion to the baby. So it is safe, but care should be taken not to cause hypoperfusion.
Great. So you hit the nail right on the head. Furosemide, in terms of pregnancy, the obstetricians usually tell you that it's in class C. In class C, usually they say that you use with caution if the benefits would outweigh the risk. So typically in pregnancy, the main thing that you need to do would be to monitor as well, because treatment during pregnancy with furosemide may lead to fetal growth restriction, because they tend to have risk of low birth weight and all of that. So it's important that we monitor. But of course, in heart failure, is the way to go. You weigh the risk versus the benefit. And since it's class C, obviously you need to use it where appropriate. I think that is the last question that we have in the chat box. Just to highlight again that I've put up an evaluation, which takes just a minute. Kindly click on the link that is put up there, and then let us know your responses to this presentation. How well did the presenter address the issue of peripartum cardiomyopathy, and what are your suggestions for subsequent presentations? Please do help us to help all of us to learn. Thanks. So there's no other question in the chat box. I would, if you have a question, kindly put up. Yeah, so Dr. Atto has his hand raised up. Dr. Atto, kindly make your contribution. You've been missed.
Thank you very much, Dr. Dominic. It's always good to be back. I just wanted to know, with the use of the dopamine agonist, the bromocriptine that you mentioned, I know it's experimental and all, but there are a few studies which have shown like very good promise with regards to its effect in remodeling or improving the ventricular function. In your experience, have you had to use it, and what was it like? Or it's not something that we've actually started to look at here in our setting? I just wanted to know if it's just in the literature or it's something that we've actually considered. And the other thing is, I like the presentation. It was very comprehensive, but for the most part, I think we struggled to really hear him. But if you followed carefully, he touched on all the important things. With people who have persistent dysfunction, left ventricular dysfunction, where their EF is consistently below maybe 35 or maybe 25, the literature also says that for such people, there might not be the need to wean them off the heart failure medication. So you may have to do the medications indefinitely if you have a patient with peripartum cardiomyopathy with persistent left ventricular dysfunction. I was glad I touched on the role of follow-up and consistently monitoring their EF as they go, because that is also very key in knowing when exactly to wean off which heart failure medication that has been introduced. So yes, all in all, I think it was a good presentation, and well done, Dr. Richard. Thank you.
Great, Dr. Atto. Always good to have you. And I'm happy that you did highlight the point on the follow-up, and then the need for the issue about bromocriptine and all of that, and what whether there's any experience with it. Truth be told, of course, like Dr. Richard did mention, its use, of course, in the setting of more or less like an investigational drug, is that also? And typically for those kinds of this, and most of the guidelines do not sort of recommend routine use of it. Throughout my practice after school, it's only one patient. I remember that was in the Tamale Teaching Hospital somewhere in 2020, specifically in December 2020, that we had as a case of peripartum cardiomyopathy. We used bromocriptine in addition to, of course, the conventional cornerstones for heart failure management. And this patient was somebody who had delivered. So we did have some experience with that. The key was like we used it together. Like if you listen to Dr. Richard, he mentioned about the anticoagulation. So we fully anticoagulated this woman. Truth be told, she was way better off, like in terms of recovery. She recovered faster than compared to those others who were there without using the bromocriptine. But in our surrounding or in our environment, I can immediately see the difficulties with it, and of course with this patient as well. Yes, that I think she was relatively well to do. Regards breastfeeding, and you know a lot of our people cannot afford other alternatives to breast milk. So those are some of the issues regards its use. Throughout my study in Kolebu, I can't remember us managing a case where we use bromocriptine rather than just the conventional heart failure medications. So these are the things that I wanted to put in. And one of the things I actually make note of was those who have persistent left ventricular dysfunction. It's great that you brought it up as well, because the patient I just mentioned in passing, this person had persistent LV dysfunction at, I think it was 28. And then the next time we're seeing her, she was pregnant after everything that was done. So sometimes it just makes life extremely difficult. But I'm sure if we keep doing our bit, we should be able to. The other thing is usually about the compliance, because the fact that you had put this patient on, gave her all the counseling, actually referred her to there was this, what's the name of the center? The reproductive health unit. I think we call it the family planning unit in Kolebu. Referred her there for her to have contraception, ends up seeing her the next time with a 4-month-old gestation. So these are my comments. I'm sure there are a couple of people who may have either the investigational use of bromocriptine in this setting who are on the call. If you do, you could kindly put up your hand, or if you have any comment or suggestion regards what Dr. Atto had brought up, or you want to even put up a different question altogether, please do. We have about 10 minutes to do this. So I see a message in the chat box. Can we get the slides, please? Yes, these will be available. As well, the Ghana Medical Health YouTube channel is active. All these presentations are being put up there. I think by the end of this week, all those ones should be up. So you could also access this. But as well, you can get the PDF version of the slides. I've just put up a number there. If you could send a message at the end of the presentation, probably in the evening, you could get this sent to you. Thank you. Any other question or comment or suggestion? Yeah, Nana's hand is up. Please go ahead, Nana.
Thank you very much, Dr. Katiba. And thanks
Hey,
again for
my good friend, Dr. Adu.
Yes, sir. I hope you are doing great.
Very well, sir.
It's been a very comprehensive presentation, and thanks so much for the opportunity to refresh ourselves. And a great kudos to the doctor who did the presentation, Richard. Please, I have a little question. Delivery.
I don't know if it is me, but I don't seem to hear Dr. Adu. Dr. Richard, could
ACE inhibitors and then the ARB. I think there are some concerns. Oh, hello. Is it better?
Yes, please. It's better now.
It's a little better now. Okay, great. I was asking regarding what he said that after the delivery, ACE inhibitors and then the ARBs can be given after the delivery. Now, there are concerns over the diminishing effects on the breast milk due to the diuretic effect somehow. I wish he could throw a little light on that, whether indeed it can really be given. Thank you.
Yeah. All right. Thank you, Dr. Adu. Dr. Richard, do you have a response to that?
Please, the use of the ACE inhibitors are mostly in patients who, if the condition of the patient is not weighing the condition, the patient, the risks or the benefit of the medication to the risks, then that's when it's advocated that it can be given. But if the risk is not as severe, or the patient condition is not that severe, then we can hold on with the ACE inhibitors. That is why they give specific the enalapril and then the captopril, but even with that one should be given with caution.
Okay, how about like following delivery? I think his question was following delivery, like on the breast milk.
The ACE inhibitors, actually the others is said to have a little bit effect on the baby and then the baby and then the breast milk, like in terms of breastfeeding. But the two are weighing the other options. The two are a little bit better as compared to the rest. That is what, so it's given when the condition of the patient warrant that we need them at least to manage the condition, and weighing the breastfeeding, weighing the managing the case over the breastfeeding.
Okay, great. So like you rightly said, with regards to is an issue more or less weighing the benefits versus the risks, and also in terms of breastfeeding and ACE inhibitors, I think the major point is rather their secretion in the breast milk, and the fact that they do have some adverse reaction, like the potential for adverse reactions for those children who are breastfed. And typically, like in adults, one of the key things we are mindful about with use of ACE inhibitors, like I always say, is hyperkalemia in the setting of renal impairment and all of that. So to the breastfed infant, obviously, if such is secreted through the breast milk, this is, of course, these side effects are real. So issues like hypotension, hyperkalemia, and all of that. So really, during treatment, you obviously want to look at the risk versus benefits. And like you would have realized as well, I think this didn't come out clear, but in terms of follow-up, like following delivery and all of that, and usually if you want to start withdrawing medications by way of the patient now being stable with the LV function being more than 50% and all of that, if the patient was previously on what we call the 4 cornerstones of heart failure management, one of the things to really start withdrawing or taking off will be the RAS system blockers, i.e. the ACE inhibitors, the ARB, or the ANI, that's angiotensin receptor neprilysin inhibitor. That is in the setting of peripartum cardiomyopathy and the follow-up management following it. Don't confuse it with heart failure management. Heart failure will reduce ejection fraction in the general population, but more of the PPCM, peripartum cardiomyopathy. So you realize that sequentially, you would be taking off the medications that do pose a risk. Essentially, the RAS system blockers, the mineralocorticoid receptor antagonists, and of course, the last usually to be withdrawn would be the beta blockers. In terms of like a stable patient who on follow-up, you realize that the LV systolic function is now gotten back to 50%, and then the patient is quite stable. So truth be told, the potential for adverse effects is more with these drugs. And so it's a risk versus benefit analysis. And then you would also, once the patient is getting better, you would want to start withdrawing the more toxic ones or those with more potential for adverse drug reactions, i.e. the MRAs, then the ACE inhibitors or ARBs or ANI. And then usually the last to go would be the beta blockers. So this is what I think the evidence that shows with regards to the use of the ACE post-delivery and the adverse events that he has. All right, I think there are more. Okay, Dr. Nabil's hand is up. So whilst he talks, then I will probably be looking at what is in the chat box. Dr. Nabil, please go ahead. You've been missed as well. It's been a long while.
Yeah, boss. Good afternoon, and good afternoon to everyone. Thank you very much, boss, for the opportunity. I think it was a good presentation, very educative, and well done to the presenter. I wanted to make a small contribution with regards to the question Dr. Ado asked. But I think you came in and made some clarification. So his question about the use of ACE inhibitors post-delivery. So post-delivery, they should be started. And enalapril and captopril have been studied, and they are deemed safe in the breastfeeding mother. You know, so unlike the more common ones, and like lisinopril and perindopril and others, which we won't go for. But if we have enalapril or captopril, we can use them. Because antepartum, we use the nitrates and hydralazine to reduce the preload and afterload in patients with peripartum cardiomyopathy. But once the woman has delivered, we are encouraged to place them on either enalapril or captopril and actually maximize the use of these drugs because of the benefit they have in heart failure. So this is just in direct response to Dr. Ado's question, because I think he asked a very specific question. So enalapril and captopril have been deemed to be safe, and we actually encourage to start them and maximize them. But like Dr. Dominic also clarified, at a point when we see improvement in the patient's ejection fraction, and we begin to withdraw drugs, we can probably start withdrawing some of these drugs because of the potential they have. But they're actually safe in the breastfeeding mother. Yeah. Okay.
Great. Thank you for the contribution. So that puts a direct response to his question. I think Dr. Richard also did mention about the safety of enalapril and captopril comparative to the other medications as well. So that's great. Thank you, Dr. Nabil. Any more questions or comments? You could kindly put up your hand and then we would allow you to. And then in the chat box as well, I don't see any. Someone is asking about certificates or CPD points to be allocated to participants. Currently, we've not registered for any with the medical and dental council. We are looking at doing this, but like you and I know, it takes money to put up these. So unless we are ready to make some commitments, or Ghana Medical Help could probably look at sourcing some funds to do this. Till then, the more important and key thing to me is to get updated with current guidelines, so that then, like evidence-based medicine, we always say, you do the right thing at the right time, and what is being supported by the guidelines. Okay, I don't see any other. If you put your number up in the chat box, it's unlikely I would be able to pick it up. Rather, what you can do is the number that I've put up there, you can send hi, I'll just send the presentation to you, because there are so many numbers that I may not be able to copy them one after the other. Apologies for that. All right, so with no hand up and without any question in the chat box, I would wish to, on behalf of all of us, thank Dr. Richard for a brilliant presentation, an in-depth presentation covering all the aspects, right from pregnancy to delivery and the moods of delivery to breastfeeding and what should be given and all of that. It was really great. He's succeeded in making a multidisciplinary approach to the management of not a so common medical issue, quite understandable to all of us. And like the take home for me is that peripartum cardiomyopathy, or what commonly most people say post-partum cardiomyopathy or pregnancy-associated cardiomyopathy, is essentially a diagnosis of exclusion. And so it's not in place that, of course, there's a cause to the heart failure, and then we go ahead to make this diagnosis. So kindly take note, and there are strict criteria to be fulfilled or to be met, like he did rightly mention. So let's take note of this. Although it's not too common in the developed world, or it's not too common in the Caucasian, it's much more common in the black race comparative to the white. So obviously, it's something that we should be looking at getting local data on. Like you see in the epidemiology that he did show up, unfortunately, it's an area that is quite gray. Even in Ghana, you don't find any much data. The closest is our brothers in Nigeria, who did have the highest rate as compared to the other countries. So it's for real. Let's be on the lookout for such and manage the patients appropriately. Keyword is that it is multidisciplinary in its management. So it's not enough that where you cannot have such a team made up of the obstetrician gynecologist, the physician specialist, or better still, a cardiologist, and a neonatologist as such to keep in your local and where appropriate, you could refer to a bigger center for such management. So we thank Dr. Richard, and we thank all of you for joining us this week. Next week, Thursday, we'll be looking at a very common topic, peptic ulcer disease. Kindly make a date with us, and I'm sure it will be interesting, and we'll learn a lot of new things that will shape our practice. Thanks for joining us, and have a wonderful week. Do take good care of yourself. Bye-bye.